All right. Hello and welcome to another APSIN didactic brought to you as part of the Multi-Site Didactic Initiative. We're pleased to have Dr. Kamper present today on the topic of neuroimaging for neuropsychologists. A little bit about Dr. Kamper. He's a board certified staff neuropsychologist and neuropsychology residency program director at the James A. Haley Veterans Hospital in Tampa, Florida. His practice includes a mix of outpatients through a general neuropsychology clinic, as well as complex and rare case presentations that he sees through his inpatient neuropsychology consultation service. Dr. Kamper developed an affinity for neuroimaging while working in a rodent lab in graduate school, during which time he also played on the lucrative scientific conferences circuit with his blues rock cover band, the Dermatones. And in his free time, he enjoys music, technology, and competitive sailing. And he's actively involved in national neuropsychology and regulatory organizations. And we're very, very grateful to Dr. Kamper for providing this lecture for us for APSIN and that we can make it available to the public. So thanks so much. I'll hand it over to you now, Dr. Kamper.
Absolutely. Thanks for that kind of introduction. Appreciate it. Can everyone hear me and see the slides okay? Uh, I'm going
Yes.
to assume. Good. Okay. Thank you. Um, all right. So great to see everyone on today. And thank you all for joining me here to talk about neuroimaging for the next hour or so. I typically like this talk to be a bit more interactive. With the size of the group, that's going to be a bit tough, but there are a couple sort of quiz items that kind of occur throughout. We can maybe try to take questions in the chat or just kind of play along at home, as it were. So let's get started. So a little housekeeping. I don't have any financial or other conflicts of interest to disclose, and as a VA employee, I must tell you that the content of this talk may not represent the official views of the U.S. government or Department of Veterans Affairs. And I won't introduce myself anymore. You can see me on the right there. All right, so let's kind of get into it here. So we're going to talk about neuroimaging today. This talk is really focused a lot on sort of the basics of what the different types of imaging that are commonly done, why they may be done, and how that can help all of us be better consumers of our colleagues, radiology colleagues' work by being able to look at scans and utilize reports. So, the first question that comes up, of course, is why? We have radiologists who are very good at this, neuroradiologists who, this is their scope of practice. Why should we care about learning something about neuroimaging? Well, there's a couple reasons. So kind of like our tests sometimes, the interpretation of some of these scans can be fairly subjective and qualitative. So an example I like to use is, what does moderate cerebral atrophy mean? What differentiates it from mild or severe? There are some newer efforts to quantify that using some volumetric sort of things, but typically it's just the interpreting physician's opinion. So it can be helpful to be able to look at a scan yourself and even just to kind of get a sense of what they mean or what the person's brain looks like when we're making our diagnoses. I'm a big believer that fluency with some of these sorts of things that we don't do but we consume, like imaging, lab work, things like that, can really help us conceptualize and be better diagnosticians and better members of a team. So if you have someone who's just exhibiting some general confusion and you know something about their imaging, if it's negative, let's say, you could rule out something like, well, they probably didn't have a stroke, that sort of thing. But it also helps us be better healthcare providers and streamline care. So if you have someone, as I have had, come into your office who's got some funky lateralized signs, knowing when they may need an imaging study. Some of your hospitals, I know, you can order those sorts of things directly, which is nice. I cannot in mine, but usually most of my physician colleagues are pretty good about ordering those if needed. Okay, so I don't want to belabor this point too much, but I do want to kind of reach back into Psych 101 or everyone's neurobiology classes back in graduate school and just get some basic definitions out of the way here. So most of the time, unless you have one of those fancy holograms or something, we're looking at imaging scans on the computer screen. It's a two-dimensional sort of thing. Most people's brains are three-dimensional, so the scans are done on the three planes that we're probably all familiar with. So we have an axial or horizontal, coronal or frontal slice, and then the sagittal slice, which is from the side. One thing to kind of keep in mind here is that scans are typically backward. Left is right and right is left. I couldn't tell you the reason for that, other than I know it's how the patient is typically positioned in the scanner. Okay, so with that kind of basic background out of the way, let's talk a little bit about CT. We're going to start with CT and tackle both CT and MRI here. CT, computed tomography, and here's a picture of someone's brain. CT is really an X-ray technique. In a lot of ways, it's very similar to the X-ray you may get on your arm or leg or something if you break it and go to the ED. But it's a three-dimensional sort of thing. So there's X-ray images taken at different perspectives in different ways. The X-rays are interacting with different types of tissue in the brain, depending on how dense those tissues are, as we'll see in a second. But the big rule of thumb, the denser the tissue, so like a skull, something hard like bone, the denser the tissue, the whiter it's going to look on CT. And you can see a CT machine here on the right. It's sort of this donut-looking thing. It's not small, but compared to an MRI, it is fairly compact, and it's taking images, like I said, from all different perspectives, and then the computer does its magic. That's the tomography part, and you get the three axes of scans. So why do we like CT? Well, it's quick, relatively cheap compared to MRI and other imaging techniques, and because of its compact size, it's pretty widely available. I mean, most every emergency department is going to have a CT, and that is a happy coincidence because CT is also really good for looking at emergent conditions. It's very, very good for picking up blood, fresh blood like you might get in a hemorrhage, foreign bodies. So for things like acute stroke or relatively acute stroke, any sort of hemorrhage, TBI, it's good for that. It's also really good for possible calcifications. So if you have someone who's got Farr's disease or something like that, where they have these brain calcifications, it's really good for that. It's also really useful for folks who have any sort of ferrous material in their body. So here in VA that may be shrapnel, but metal implants are not uncommon. Certain types of pacemakers that aren't MRI safe. As we'll learn about with MRI in a bit, having something metal in your body that's subjected to a strong magnetic field is typically not a good idea. We like pacemakers and such to stay where they are and not move around. So sometimes even if someone should maybe have an MRI, they're going to do a CT just because better than nothing. So here's sort of a slide that's showing just in general how tissues appear on CT. So I spoke a couple of slides ago about denser tissues are appearing whiter. And you can sort of see what that looks like here in this continuum that I have at the top of my screen. Things like air, fat, fluid like CSF are going to be darker. White matter is slightly less dense than gray matter, so it's going to look a little darker. And you can see that here on the right-hand side of your screen. This CT scan that has, you can actually see the white matter here and the gray matter overlying it. You can obviously see the skull. You can see the person's scalp and the fat underneath it. And then, of course, the ventricles and these are the typical like choroid plexus calcifications that you get with aging. This is a normal scan. We'll look at some abnormal scans here in a minute. But just a couple other things to keep in mind. So we talked a bit about how fresh blood, like you might get with a hemorrhage, is going to be nice and bright, so it's easy to see. As it resolves, it gets less bright, so isodent and then hypodent, so it's a little harder to see. There is a term you may have seen in reports that will talk about the gray-white differentiation. That's important because the lack of that is indicative of typically an ischemic stroke, as we'll see here in a few slides. Most tumors are hypodense when there's not contrast as well. But you can see on the CT the midline quite well, so looking at things like midline shift and those sorts of neuroanatomical changes can be pretty easily done too. Okay, so this is that white matter, gray-white differentiation thing I was talking about in the prior slide. So this is the natural progression here of an ischemic stroke. The interesting thing is you may not get any positive neuroimaging for someone who's had a stroke in the first couple hours after the stroke has occurred. So, and I hope this is big enough on your screens. You can see here on the left this CT, which is showing fairly normal. You can see the white matter and the gray matter and things like that. But I want you to look here at the middle study here. So this is a day later. It's a little hard to see, but if you look at, so this would be the left hemisphere, right? Everything's flipped. You can still see that gray matter and white matter change a little bit here. But on the other side, so it's like a right MCA territory, you can see it all kind of looks the same. That's that loss of gray-white differentiation they talk about. And what happens is, typically after ischemic strokes, due to different neurophysiological processes, of course, there's fluid that gets retained, water, called edema, and that's what actually causes this lack of gray-white differentiation. So that's what you're picking up. Months later, that stroke has resolved into an area of encephalomalacia, which you can see here, which is the residual effects of the stroke. I've used these slides before and been asked what this is here on the left hemisphere, and this is probably just the way that the scan is, just the cut. But the pathology's over here in the right MCA territory. Okay, so let's talk for a minute about contrast agents. So contrast agents are used in both CT and MRI. In CT, they're typically iodine-based, and they have the same purpose with either type of neuroimaging technique or study. So they're being used to enhance the visibility of blood vessels or things that have lots of blood vessels in them. So tumors and such, abscesses. So you can see here, down below, that this image on the left, there's something happening here in the left hemisphere. Again, it's flipped. And you can see pretty much complete effacement of the right lateral ventricle. It's really not appearing, and this midline shift as well. So something's imparting mass effect. It's a little hard to tell what that thing is. You can see here the left lateral ventricle. But then if we add contrast, you can see this ring enhancement here, and this would be indicative of something like a malignancy that's putting mass effect. So this would be like left to right mass effect with right lateral ventricle effacement from something, a tumor probably. Okay, so CTs can often go right, but sometimes they can go wrong as well, and they can be subject to some artifacts, which is anything that's degrading the quality of the scan. So some of you who are in the habit of reading the reports from your neuroradiology colleagues may see, especially things like movement. They might say, something in the report about the scan quality is degraded due to movement or something like that. And that's going to look kind of like this. So There may be some weird looking bandings or some blurriness on the scan. CT is relatively quick compared to MRI, but if you have someone, let's say, who's in a post-traumatic confusion or a delirious, other type of delirious state, and they're not able to stay still, you're going to get some movement, which is going to degrade the quality of the scan. Another common artifact you'll see with CT is metal. So anytime there is metal in the brain, which isn't supposed to be there typically, that oftentimes will be like a GSW, the remnants of a bullet fragment, or an aneurysm coil or implant or something like that. It's not going to move around with CT, thankfully, but it is going to kind of screw up the scan. So this is a pretty bad example here. And by bad, I guess I mean it's pretty stark, but there's something metallic here, something quite dense, probably a bullet, and it's really screwing with the resolution of the image surrounding it. Oftentimes, if it's smaller, something like an aneurysm coil, you may see a little bit of this sort of starburst effect or a black hole or something like that on the scan, and that's the signal getting degraded by that artifact. You can also see very occasionally miscalibration or defective scanners here, like this water droplet looking thing here in the bottom right hand corner. Okay, so we've gotten to the part where we have some practice. So if anyone is brave and wants to take a stab at what we're looking at, feel free to write in the chat. Otherwise, you can just play along at home. So on the left-hand side here, we've got obviously a CT of the brain, and something's going on. I'll take a peek here at the chat to see if anyone does chime in. If not, no worries. Okay, we've got a couple people who have hazarded guesses that we've got interventricular hemorrhage. You are both correct. So you can see here, nice and bright. This would be fresh blood in the ventricles, more so in the left ventricle, lateral ventricle, but you can see here a little bit in the right as well. The reason you can't see the rest of the right lateral ventricle is probably just the orientation of the person in the scanner. But very good. All right, how about this right image here? So we've got something that's imparting some pretty notable right to left mass effect. You've got the ventricles kind of getting squished here. You can see the pineal gland, which is the normal calcification, and it's kind of pushed out of the way. And we've got, yes, so everyone who's chimed in has some sort of mass on the right side with midline shift, probably a tumor, absolutely. Could be a meningioma, but most likely a GBM given the size, and you can see here the center is hypodense, so it's got a necrotic center and then this ring of edema along the outside, so most likely a GBM. Or a massive abscess. Yeah, that's possible too. Okay, and here we've got, this is the same brain from both the horizontal and coronal slices. Yes, I don't have prizes to hand out, unfortunately. Thank you, Dr. Mapo, but if I did, there would absolutely be some sort of candy reward or something like that to increase that blood glucose. Post-resection, that's a really good guess. I will give you a hint and say that what we're looking at is something, the result of something that happened about 3 to 4 months ago. An infarct, stroke. Yep. Yep, an old stroke, exactly. So what we've got here is probably what? Right MCA territory, encephalomalacia in the frontal parietal. Well, it's getting a little temporal here too. Pretty big area of encephalomalacia from an old stroke. So good job, everybody. Yes, for those of you keeping score at home, we've got a couple winners here. Very good. All right. Okay, so this is something we're probably all at least somewhat familiar with, but I want to talk a bit about different types of bleeds that we may encounter. So epidural versus subdural versus subarachnoid. So here's a cartoon of what that looks like, and courtesy of, I'm assuming it's not the actress, but Lucy Liu. So an epidural hematoma, and some of you who have been following the news and saw the passing of Bob Saget here down in Florida a few months ago, I think the suspicion was that he had an epidural hematoma. It's arterial blood that rapidly expands, and because it's between the dura and the skull, it's going to push down and really cause this sort of blunt-looking mass effect. With the subdural, it can be a bit more subtle, but it's going to kind of fill in here below the dura. And then the subarachnoid can be a bit harder to see because it kind of fills in the gaps. So here's an example of what all of those look like. So here's epidural, and here is a subdural here. We can kind of see that lensing with some pretty significant midline shift. And the subarachnoid oftentimes will look a little bit more like I said, like it's kind of filling in the gaps. So let's take a peek here in a second at what that looks like that. So this is what a subarachnoid would look like. Okay. And I see in the comments here that, yes, bleeds can oftentimes be fairly obvious. The sort of rates of agreement among neuroradiologists, if you present a bunch of people with a scan and have them interpret it, the rates of agreement on what the problem is are shockingly low for most things. Thankfully, acute hemorrhage is not one of them. There's pretty good reliability and agreement between providers. But when things get more subtle, it gets a bit tougher to interpret. So one of those more subtle things that we can often see is with NPH. So sometimes, especially in older individuals, it's hard to tell if the problem is that there's too much space, like an ex vacua dilation, or whether there's too much fluid, like NPH. Particularly if there's some volume loss, it can be a little hard to see. So one thing you may see referenced in a report is something called the callosal angle. And what's done on a coronal slice like this is the angle of the corpus callosum here with the ventricles is measured. A normal angle, which is here on the right, is typically 100 degrees or more. And I'll get to the scans here in a second. With NPH, the callosal angle is more narrow. So you may see something in a report about a narrow callosal angle, typically followed by something like clinical corroboration is recommended. So some other clues here, and this is cheating because on the right here we have an MRI. It looks like a T2 MRI. We'll get to that in a bit. But we can see not only is that callosal angle a bit more obtuse, but you can see the white matter disease here. And you can also see some, the normal gyri and sulci to some degree, as well as some volume loss. And that's pretty indicative, not always, it can get a little bit tricky, but oftentimes that's indicative that the problem is not hydrocephalus, NPH. The problem is that there's been some volume loss. On the left, with this CT, you can see this is actually some CSF that's pushing its way into the brain parenchyma here. And that loss of the ability to see the gyri and the sulci, things kind of get squished up against the skull. This is a cleaner example. Again, sometimes it can be a little hard to tell, but this would be more indicative, of course, of NPH. All right, so, CT seems pretty great. The question may be, what are some problems with it? Well, it's not as detailed as MRI, as we'll see. CT does use ionizing radiation, not, the most. It's not as much as, an abdominal CT or anything like that, a head CT. But for frequent flyers to an emergency room who are getting repeat scans, it can be a significant radiation dose over time. Because there's ionizing radiation, typically it's not indicated with pregnancy if someone's obviously got a contrast allergy. Or if there's other considerations, but most often CT is fairly well tolerated, and like I said, every emergency department pretty much is going to have one. If you go in and say you hit your head, you can bet they're gonna give you a CT. Okay, so I like to have some sort of whimsical, terrible movie usually as sort of something to break up all the fun here of learning. Today's movie is the movie Cats, which is terrible, of course. The recent Cats movie. I apologize if anyone's a fan. Um, so here's our rest stop, courtesy of some very weird dancing. If there's any questions or comments that anyone has, feel free to put them in the chat. Otherwise, we are going to move on and talk about MRI. Thank you, Dr. O'Connell, with the yes, it is a real gem. I've previously featured movies like The Room, which some of you may know, but that's a bit more esoteric. I thought, something that kind of appeals to everyone. It's good for folks of all ages, like cats. Okay, so let's move on and talk about MRI. MRI is very, very flexible and could be, multiple hours of talk in its own right. So we're going to try to cover the major aspects of structural MRI in particular, with a little talk about functional imaging here towards the end. So first, I appreciate the room call out. Thank you. So first, some background here. So it's hard to tell from the cartoon, but the hardware for MR is huge. You can fit an entire person inside compared to CT. So it takes up a lot of room, and that's because it uses superconducting magnets, which is super awesome. But it takes a lot of room and a lot of energy. What happens is basically you have this very, very strong magnetic field, and the person typically is going to wear maybe like a head coil or something that is going to adjust the magnetic field to allow for the cross-sectional slices that we see. And there's radio frequency pulses and all sorts of things that they can time and change the administration of. But basically, without getting too much into the physics of it, when you align things in a magnetic field and then let them relax back to how they were, it spits out, it doesn't spit out an image, the computer does that, but it spits out a signal, and that's actually what makes the image. And different types of MRI, that's done a bit differently. You may see a number assigned to the MRI. That's the strength of the magnetic field in Tesla, which directly affects the details. So 1.5 or 3 Tesla is fairly common. I think there's a 4.7 or something that's being used in some centers now. When I worked with rats in grad school, we had an 11.7 Tesla MR scanner, which was very, very detailed. But anyway, so MRI is much better resolution and contrast than CT. In a lot of ways, there's fewer artifacts except for movement. MRI takes longer to do, so the movement can be a bigger deal. Having the multiple techniques and being able to time, the radio frequency pulses and such with the magnetic field means that there's lots of different ways to visualize the anatomy, which can be super helpful. It's really good when there's non-emergent things because of the time it takes. So normal anatomy for research studies, anything non-emergent, inflammation, demyelination, white matter changes, etc., as well as blood flow, changes in blood flow too. I think for our purposes here as neuropsychologists, the inflammation, demyelination, white matter changes, and non-emergent pathology is probably more fitting in what we're interested in, unless you're working in an ER. So I want to take a few minutes here and talk about the basic types of scans that you're going to see. So the first here is our good friend, the T1. So T1 MRI is good for anatomy, basic anatomy, as well as the borders between the brain and the CSF. It's less sensitive to lesions. I'm not going to read all of the items here below, but just kind of know that you can see the CSF is darker, and the white and gray matter are lighter. This image here, it's actually pretty clear to see basal ganglia. You can see the internal capsule here, probably the external capsule over here. So neuroanatomy is regular anatomy is pretty easy to see on a T1, and it's useful for some other things here, as we'll see in a second. But this is kind of a good basic scan. Okay. And that's in opposition here to the T2. T2 is best for most types of pathology, including lesions. The bummer is that it can't distinguish lesions from CSF all the time, so this arrow is pointing at some, looks like some maybe callosal changes here, but anything that's right up against the ventricles is going to be a little hard to see, but it's really good for looking at white matter and demyelinating sorts of things. T2 is based on protons and how they relax, and again, the physics are sort of outside the bounds of the presentation today. But something just to kind of keep in mind, it sort of looks like the opposite of the T1. So the ventricles are going to be brighter, and the brain parenchyma itself is going to be darker. So one way to kind of fix the shortcomings of the T1 is with, or the T2, excuse me, is with the T2 flare. Fluid attenuated image recovery is what it stands for, I believe. So it's like a T2, but the computer basically takes the CSF signal out. So the pathology is still nice and bright, but the CSF, the ventricles, are now dark, and this is very, very useful for lesions around the ventricles. Things like white matter disease, which we can see here in the image on the right-hand side. This is periventricular white matter disease. Inversion, yes, thank you. Appreciate the comment there. So this looks like a T1. Pathology is brighter, but it's really good for our purposes. Okay, and we're going to talk here about contrast as well. So this would be probably an infratentorial tumor of some sort. You've got some mass effect here. On the left-hand side, this would be a T1 MRI. It's a little hard to see what's going on other than you can see some of the normal anatomy that's at midline is pushed out of the way. When we add contrast, not only can we see the blood vessels, but that tumor shows up nice and bright. Contrast, as we'll see in a slide or two with MRI, is used similarly to CT, but it works a little bit differently. But here's that very same tumor now with T2 and flare. And what's interesting to see, so here's your regular T2 on the left. You can see some CSF. The reason that you're seeing white here is probably CSF or edema. There's fluid around the tumor, and that's getting nulled out with the flare. So it's actually a little easier to see on the T2. But that's an example of the different MRI techniques and how they're used to image the same sort of pathology here. Okay, so one other thing to kind of look at, and this at least probably in most centers is typically done, is the DWI and ADC. These go together. So DWI is the diffusion weighted coefficient. It's sensitive to how water is moving, and when there's edema, like we talked about with the CT due to ischemic stroke, sometimes seizures and abscesses as well. But that's going to restrict the movement of water, and it means that that water can't diffuse like it normally would, and so it's going to show up bright. DWI is based on T2, so you can see here it's bright. The problem with DWI is that there's a high propensity for artifacts. Shine-through artifact is something that you may see referenced where there's sort of false positives, and you're seeing bright areas where there's not actually pathology. So what they often will also do is the ADC, the apparent diffusion coefficient, where the same corresponding pathology is dark. So you're seeing if it's bright on DWI and dark on ADC, that is typically pathognomonic for something like an ischemic stroke. So if you're reading a report, you may see something about DWI, ADC, something. They'll kind of interpret that together. All right, and I apologize that the individual brain slices here are kind of small, but this was a study from 21 years ago. Wow. But it's just showing how a stroke can appear on different types of scans and what that looks like over time. So let's go through this here real quick. You can see early on, relatively early, 19 hours post-stroke, you're seeing some ADC and DWI abnormalities, and you can see the corresponding um, signal changes there. Uh, and those get brighter and darker over time, more notable. Uh, but interestingly, by 27 days later, DWI is still nice and bright, but the ADC has kind of resolved. And that's indicative of sort of the natural progression of the stroke. So initially there's that acute ischemia and that edema, so that's showing up. But by the time you're 27 days out, what you're seeing is more of those encephalomalacia type changes and things like that. So there's no longer problems with diffusion, but the DWI can't tell the difference, like we talked about on the last slide. So if we go up to T2 and T2 flare, you can see again early on, it's harder to see, this restricted diffusion. But by the time we're getting a couple days out to a week to 27 days, it's a lot easier to see. And again, I apologize how small this is. But the T2 and flare become much more useful a little bit later on. ADC flare, you can kind of see the corresponding changes there as well. So this just kind of shows how the different MRI techniques and scan types can be useful depending on what you're looking for and looking at the natural history and progression of something like a stroke. Okay. So I also want to talk just a little bit about gradient recalled echo. So this is a really cool type of scan that's used to highlight tissue differences, and it's really, really good for looking at hemosiderin deposition and other blood products that are non-oxygenated. So for those of you who are do a lot with stroke, hemorrhagic stroke in particular, or TBI, you may be familiar with hemosiderin. It's the iron deposit that's left behind when blood gets reabsorbed. So if you have a hemorrhagic stroke, TBI, something like that, anything that's going to cause blood to be where it shouldn't be in the brain, eventually that blood gets reabsorbed, but this hemosiderin gets left behind. And a GRE MR can detect that. So we've got kind of two things that are done. There's either the T2 star, which is here on the left, which looks like a T2, right? Ventricles are nice and bright. And you can see these little bits here. This is the hemosiderin deposition. And then on the right-hand scan, and then it's blown up here on the far right, this is the SWI, susceptibility weighted, which is more sensitive than T2 star. At least at my hospital, they don't normally do this, but I really love when they do this with the folks who come in and say they had a severe TBI 20 years ago, and you're thinking, I don't know, that kind of doesn't make sense. This is a nice way to tell if there was a TBI and there was any sort of blood product, this would definitely pick it up. So the case that we're looking at here is a case of, I believe it's cerebral amyloid angiopathy, when you get amyloid deposition in the blood vessels in the brain and get these little microhemorrhages. So the question here in the chat, and looks like there's a conversation going, which is great. But the question here from Dr. Reyes is, can this be helpful for looking into old microbleeds? Absolutely. It's great for that. Unless your radiologists like to use giant slices like ours sometimes do. If they're doing either T2 star or ideally SWI and using thinner slices, microbleeds and things will absolutely pop. And you can see that with CAA here. These bleeds are pretty small. They're going to be real hard to see on a normal T1 or T2 MR, but on this, especially on the SWI here, it shows up really, really, really nicely. So yes, absolutely. Okay, so just another word about contrast agents. We talked briefly about contrast agents with MRI a few minutes ago. Iodine is used for CT. They use gadolinium for MRI. but it's for the same purpose. So you're looking for highly vascularized objects, vasculature, scars, inflammation, infiltration, etc. So think tumors, active MS lesions, blood vessels, etc., or things in the blood-brain barrier. So here we can see, so this would probably be a T1, right? MRI, some sort of little swirly thing here in the left hemisphere. Maybe a touch of mass effect, but not too bad. Kind of hard to see what it is. When you throw some contrast at it, though, you can definitely see something's wrong. This may be an abscess or something. So, question of unidentified bright objects. I will try to come back to that in a minute. Yes. On the right-hand side here, this is a normal, probably T1 as well, and you can see some of the blood vessels here, which is kind of cool. I don't really know much about the unidentified bright objects. I would imagine that's one of those things that they don't know what it is. Maybe an artifact. Sometimes, especially with T2 type scans, you can get the shine through artifact. So something that doesn't really seem to match up with any sort of pathology, and it's just sort of an incidental weird calcification or something like that would be my guess, but I don't actually know for sure. So I might be right, Dr. Mahaney. I hope I am. Yeah, so the normal calcifications, we didn't talk about those as much, but especially on CT, you can see the pineal gland and in the choroid plexus. I don't want to go back too far, but if you're reviewing this talk later and looking at some of those early CT scans, you can see the bright signal at midline and then in the ventricles. That's super normal as folks get older. I think after 30, it's more the rule than the exception. But basal ganglia calcifications, Falk's calcifications are not necessarily abnormal either with aging. As far as the neuroquant, I don't know a whole lot about it, so I'm going to avoid trying to opine. But I do know that if I'm remembering correctly, I think it's kind of controversial. But unfortunately, maybe if we do a part 2, we can talk about that. But I don't have any of that today. Dr. Mooney, a teratoma, maybe. Teratomas are oftentimes those nasty little tumors, right, with like hair and stuff that grows inside. But I do know that they're not horribly abnormal, so that's certainly possible. Okay, so brief word here about artifacts. You can get them with MRI, and movement's the big one. So this upper right is a great example of movement artifact. You have to sit real still, lay really still in the scanner, so MR is very prone to movement artifacts. You can also get funky things like black holes with metal, not the kind of metal that moves around, but I think this is like a dental implant. And this weird, you'll see it often described as like a CSF flow void. You can see it looks kind of like a ghost, either so this would be in the spinal cord, but you can see that around the brain as well. Sometimes there's some sort of ghosty looking thing. That's just normal CSF flow. All right, so we're going to practice a bit more. Unfortunately, Dame Judi Dench found herself cast in cats. I'm sure she won't forget about that anytime soon. Again, feel free to chime in the chat. So on the left-hand side, we've got an MRI scan, obviously. So I often like to ask people what sort of scan. So if you want to think about that for a second, I will not give away the answer. But what do we have here on the left-hand side? It's a flare, T2 flare. Dr. Miski, that is absolutely correct. Very good. Infection's a good guess. It's not infection. Dawson's fingers. Yep. So yes, to all of you who talked about MS or Dawson's fingers. So Dawson's fingers are essentially pathognomonic for active MS lesions, and you can see it's periventricular, but they sort of extend upwards like this on a sagittal slice with T2 flare. That's exactly right. How about on the right-hand side? So what sort of scan is this? T1, T2, T2 flare, ADC, etc. This is a T2 flare. And what's the pathology? What are we seeing here? And I'm seeing some guesses in the chat. Periventricular white matter disease, periventricular hyperintensities, all of that is correct, yeah. Leukoariosis, which is my favorite fancy way to say it when you need to be pedantic. But yeah, this is white matter changes, like we often see. This is probably a bit more severe. It's not just conscribed to the ventricles here, but yes, white matter changes, very good. All right, left-hand side, what do we got? Diffuse axonal injury is a good guess, Dr. Jackson. It's a T1. Yep, it is a T1. And there's a guess from Dr. Stuart Willis of lacunar infarcts, thalamic infarcts. Yes, I would say both of those are probably correct. These are lacunar infarcts, at least, yeah, probably at the level of the thalamus, yes. But this is what they look like, the little lacunes or little holes here, which I'm sure everyone's seen referenced, many, many, many times. But this is what they look like on a T1. If this were a T2 or flare, you might see a little bit of edema around that, or just CSF. But on T1, here's what they look like. All right. And there's a good, okay, so Dr. Milliken has a question in the chat here about what is confluent white matter lesions. That's a really good question. Well, we can talk about that for a minute, sure. So the answer is, good question. I don't think there's a answer that's going to be universal, and that's going back to kind of the reason for the talk of why it's helpful to be able to look at the scans yourself. Dr. O'Connell says eyeballing it. Yes, that is correct. In theory, confluent means the white matter lesions that have sort of grown and overlap, and now it's just sort of one big white matter lesion. But eyeballing it is about right. Confluent, for those of you who don't know, typically that's going to be more indicative of more severe white matter changes. But I've seen them described as patchy. I've also seen patchy meaning they're very small, but they're multiple places. So kind of the opposite of confluent. So in theory, confluent is bad, but it's helpful to look for yourself. Someone may describe this left periventricular, white matter disease here as confluent. I doubt, all would, but oftentimes it can be, a lot more severe. But great question. And this kind of goes back to the subjectivity sometimes. Okay, so we got the lacunar infarcts. Let's go to on the right here. So we've got two scans. What are we looking at? What type of scan and what is the pathology? What's going on? DWI and ADC is correct. T2 star is not a bad guess. Yeah, so this would be an acute right MCA stroke. Very good. Pretty large one. And the restricted diffusion, again, the key is bright on T2, or on DWI, excuse me, and dark on ADC. You need to have both. All right, and here's another example. This is, again, the same patient. What are we looking at here? What type of scan and what is the pathology? CT, it's actually, so this is not CT with contrast. That's a very good guess. This is probably T1 MRI with contrast. And I find that CT looks a little fuzzier, kind of. That's why I know it's an MRI. Could be an endoplastic meningioma. I think this was, at least from Radiopedia, which is a great resource, by the way, if you don't know Radiopedia. I think this is GBM, but could be an endoplastic meningioma. That's not a bad guess. All right, how about this one? This one's quite a little trickier. So let's see if anyone knows. We are looking at probably, what is this? Flare, probably. T2 flare. What is going on with this patient? Wow. Got some good guesses here. Active MS lesion, inflammation, or press. Anoxia. Good guesses all. I do believe this is a case of PRESS, posterior reversible encephalopathy syndrome, so also called hypertensive encephalopathy. The reason I think it's that, other than that's what the case was described, where I got the images here, is the sort of ghostiness about it. It doesn't look quite as starkly white as what you might see with actual inflammatory lesions or something like that. It's a little bit milkier and more diffuse. Press is a topic for another day. It's not always posterior. It's not always reversible. But typically it's going to occur in the posterior regions due to fluid leaking out of the blood vessels from a hypertensive urgency. Anoxia, Dr. Jackson, that's an excellent guess. That can often be seen more, anoxia likes the medial temporal lobes because of all the resources that they consume. We can talk about that certainly if we end up doing a continuation of this or in the handout that I'll provide. All right, so just a few minutes left. Why wouldn't we do an MRI? Well, it's more expensive and slower than CT. So if there's something that's emergent, you probably do an MR eventually, but CT would be first line. It's loud and tight in the machine, so claustrophobia can be a concern. Single administration of something like diazepam is pretty common, but sometimes patients can't fit in the bore of the machine either, so there's open MRIs too. If you're agitated or dyskinetic, unless you're sedated, the movement artifacts are going to be too great and it may be quite hard to read. Anything that's likely to move, so again, we talked about that a little earlier, is bad. We want pacemakers and such to stay where they are. The gadolinium contrast agent can also be hard on kidneys, so anyone with kidney disease, sometimes that'll contraindicate at least the use of contrast. But because there's no ionizing radiation, typically it's pregnancy safe. Do some tattoo inks make MRI contraindicated? I want to say yes. I feel like I have seen or heard that. Someone can correct me if I'm wrong in the chat, but I believe yes. If anything had any sort of iron, anything ferric in it, that could be an issue. Not the modern ones. Okay, thank you. So yeah, old tattoos, and sometimes I think if you don't know what it is, same thing with the pacemaker. Some pacemakers are MRI safe, but if they don't know the make and model, they typically won't do it. Okay, so the short version of this talk is, to sum up everything, CT is quick. It's good for blood, bone fractures, malignancies, acute things, hydrocephalus. MRI is long, takes 45 minutes at least for a full thing without contrast. But it's particularly good for active white matter lesions and things like that. And there's a link in the chat there about tattoos. That's helpful. Thank you. So just a second here to talk about functional imaging. This, could be a talk in and of itself, of course, as well. Functional imaging is, let's talk about fMRI first, very quickly. So there's this phenomenon called BOLD, blood oxygen changes here. So when you have changes in blood flow in response to increased brain activity, that's going to, of course, change the amount of oxygen in the blood. And that change in oxygen is viewable on MRI. And you can see fMRI scan here below. So the scanner will interpret those increased oxygen signals. It's not directly indicative of activity, but it's correlated with activity. And then the coloration is added later. fMRI, I think at least in most centers, is not used as much, as a general imaging technique or protocol to go with. It's used more in research. They do use it for those of you at epilepsy centers. You may be quite familiar with it for pre-surgical planning and things like that. It's being used more in that respect. But it's hard with N of 1 patients sometimes to really tell what's going on. And some of you may be familiar with that dead salmon study they did, I think, up at Dartmouth a few years ago, where salmon purchased at the meat market, frozen, definitely dead on ice, had fMRI activity. Just shows some of the challenges here, but still useful for pre-surgical planning or in research studies. PET uses super cool. They inject radioactive glucose into you, and you create radiation, which is detected by the scanner. So the scanner itself is passive. It's sort of a similar idea, but rather than blood flow, areas of the brain that are using more glucose are going to absorb more of this radioactive glucose and are going to show PET findings. PET's also used a lot for looking for cancer mets and things like that, whole body PET. So PET is not diagnostic for our purposes typically. You can't diagnose Alzheimer's disease off a PET scan as much as some of the folks at my hospital would like to think you can. But it's useful for things like differentiating FTD from AD. You can see upper right here, there's some frontal hypometabolism. And with AD, it's more of the mesial temporal hypometabolism. So it can be useful for differentiating some things, but obviously you can't diagnose from that. So Dr. Maypow has a patient diagnosed with FTD based on PET, and your eval didn't support that. I've run into that many times actually. There's a couple providers who love to order PET scans, and I have a little blurb about, as a neurobehavioral diagnosis, you can't diagnose something like a dementia off of a scan. You need clinical corroboration. That's what we do. So it can be supportive, but it's certainly not diagnostic. Thanks for bringing that up. Okay, we are out of time, unfortunately, but we do have a couple more practice things. So if I need to stop, please let me know, but it'll be just another minute or two here. So let's just get a little bit more practice, and thanks for everyone who has to jump off right at noon. Appreciate you coming and attending the talk. So the left hand is normal. There's low subcortical microvascular burden, no significant atrophy. All right. The age of this patient is age-ish, I don't know, let's say 70 or 75 or so. That's a guess. Okay, so the left-hand side is a normal patient. The middle one, as you can probably see, those ventricles are quite large, but there's also quite a bit of volume loss. So this could be a case of NPH, but it's more likely to be ex vacuo dilation, hydrocephalus ex vacuo, central predominant volume loss. There's lots of ways to describe it, but unlikely to be NPH. And on the right-hand side here, you can see there's quite a lot of white matter disease and some modest atrophy here too. All right, and this is, I think, my last one here. So what is wrong with this picture? Upper left is the first one. I'll give people a chance to kind of think here. So this is bifrontal degeneration, like you might see with FTD. Frontal atrophy, very good guess in the chat there. Thank you. I think the next one is bottom left. This is the T2 MRI. So bottom left is a little more subtle, but if you look at those, and it might be hard to see with the size of the image, but if you look at those temporal poles here, you can see the one right-hand side of the scan, that'd be the left temporal pole, is smaller, so that's asymmetric perisylvian atrophy. You can see it here, right? Upper left or upper right here, you can see there's some difference left to right, which is a nice way to kind of compare when you're looking at a scan. Look at the left-hand side compared to the right-hand side. NPH is a good guess. You can see here the gyri and the sulci are still fairly visible, so probably not. Hippocampal atrophy, perhaps. Probably. So they called this left temporal pole atrophy, but since we're seeing lateral ventricle here, I would suspect it's probably, I mean, it's bilateral, but worse on the one side. Yeah, good. And then the bottom right, so the bottom right demonstrates something kind of interesting and important, which is oftentimes with aging, you're going to get more just normal volume loss in the frontal lobe. And you can see that on a sagittal slice quite nicely. When you're seeing more volume loss in the posterior part of the brain, that's going to be a bit more abnormal. And something like PCA, as a couple of you are chiming in the chat, is an excellent, excellent guess. We, of course, can't diagnose PCA from the scan. You'd need one of us to do that, but the actual atrophy that could support that diagnosis, absolutely. This is probably would correspond to what you'd expect with a PCA case. Yeah, very good. Okay, oh, there's more. I'm sorry. I know people have to go. Let me just go through this very quickly. Left-hand side PET is normal. Middle PET is parietal occipital hypometabolism. And then you can see on the right-hand side, those ventricles are pretty huge. So there could be something there, either just, ex vacuo or maybe even NPH. What they want you to see is that the frontal poles, there's hypometabolism here. All right. Okay, and we've finally reached the end. So thank you, everyone who's been able to stay on here. I don't know if we have time for questions, but if we do, feel free to put those in the chat. And apologize again for exposing you here to everyone's least favorite movie. But
there are a couple of questions, Dr. Kamper, from earlier in the talk. And we'll post this on the ABSIN library website, like I said, so that people can fast forward to the questions if they hopped off early. If you have time to answer them.
Yeah, absolutely.
Okay. One person was asking about characteristics that you look for on imaging to differentiate tumor types. And specifically, she said, during the CT portion of your talk, you mentioned the center was hypodense, so more likely to be a GBM versus meningioma. But she was looking for more information on what that means and if you can differentiate types of tumors on imaging rather than just identifying the tumor.
That's a really good question. If we end up doing a bit more on this at some point, that would be something I think that would be cool to dive a bit deeper into. The short answer is yes. I mean, oftentimes I know they'll have to do biopsies and things to see exactly what the pathology is, but certain tumors are known to show up certain ways. So something like a GBM oftentimes has a necrotic center, which is why it shows up with hypometabolism on CT. But not all tumors will do that. So sometimes if it looks a bit more uniform with that ring enhancing, it can be a different type of tumor. And there's some kind of peculiarities there. It gets a bit into the weeds, but I'm happy to chat about that more at some point here. But great question.
Another specific question, somebody said that their radiologists are fond of saying moderate central atrophy with mild or minimal cerebral atrophy. And does that mean NPH?
No, good question. So central atrophy typically means like, ex vacuo dilation, hydrocephalus ex vacuo. It means the ventricles are big because there's volume loss, essentially is what it means. When they talk about cortical atrophy, I mean, it's sort of two sides of the same coin, but cortical atrophy would kind of be from the outside in, I guess, and the central atrophy kind of from the inside out. So whether you're seeing brain volume loss because the ventricles are big versus those sulci have widened quite a bit, or both. So yes, some radiologists there's certain things they like to say. So I can imagine someone would kind of be fond of that, but that's kind of what that means. It's looking at the ventricles being large versus the cortex being kind of loose.
And did you see Dr. Mooney's question? in the chat, any thoughts about Eklund and colleagues' work a few years ago about the concerning disagreement/false positive rates between different fMRI software packages?
That's a great question. I, I'm not super familiar with that work, which is probably a failing on my part. So I will opine, but just somewhat, based on kind of the context of the question. Um, you know, Thank you for the link there. I That's one of the drawbacks with some of these functional imaging studies is the software packages and how the actual, because the coloring is added later. So oftentimes how the scan is actually done can change between centers. So if you're doing everything like for a research protocol in the same hardware with the same, interpreting radiologists using the same software, that's fine. But when you look to compare between centers, that's a problem. And I believe that's why things like, so there's like this new amyloid PET that you may have heard of that they use for AD. There's been some popular press articles about it being kind of the new big thing, but I don't believe it's actually approved for clinical use, and it's for that exact reason. In research studies on one scanner, that's fine, but when you get an N of one patient in a specific place on a specific set of hardware, it's a little bit harder to kind of make anything out of that. So I hope that answers your question to some degree. I'm going to take a look at the paper, but I do know that's kind of been an area of contention.
And then there was one other question and one other conversation that went on in the chat. I don't know if you had time to read it, so I'll mention it. But the question was, how do you determine subdural hygroma versus atrophy?
Subdural hematoma versus atrophy. Good question. So with the subdural hematoma, you would look for blood, or it would be blood, but it's venous blood, so it's less pressure, so it's not going to be as emergent. But you're going to see kind of a lens, it looks like, of white. That's the hyperdense blood, and it's going to cause some mass effect often, or kind of push structures to the side. So one useful thing to do is to look at the left side of the brain versus the right. Sometimes folks can be in the scanners a little crooked, but it's kind of a good way to look at any differences. So if you're seeing that the falx, for instance, is not in the middle, or if the ventricles look a little squished or kind of pushed to the side, and you're seeing some hyperintensity on CT, for example, along the outside of the brain, that would be a good example of something like a subdural. With volume loss, unless it's due to something like seizures or something that's going to be asymmetric, it's oftentimes going to be symmetrical. So even in FTD, not always certainly, but you'd look for kind of bifrontal, or with Alzheimer's disease, oftentimes it's bitemporal atrophy. So it's one specific area though that's sort of atrophied, and you're not seeing things getting pushed out of the way and then no blood being present. One other quick thing that I saw was being discussed in the chat was kind of indications for ordering imaging, which is probably could be a whole discussion. Personally, I'm a big fan of trying to be a team member and recommend things. How that's received can sometimes depend on the provider. So I personally am less likely to tell someone they need to order an MRI if my consult's coming from neurology, who knows much better than me. But if it's coming from primary care, that might be that's a different story that I may. I know the culture at different hospitals can be different. At my hospital, folks tend to be super open to that, which is nice. I've done that with EEG, not ordered it, but recommended and had someone order EEG before, and things like that. When there's get neurology involved, but you may want to consider an EEG too, that sort of thing. So it depends on the center. I know sometimes some of the physicians can be kind of prickly about that. But at least at my hospital, folks are fairly collaborative and open, so I haven't run into too many problems. But again, I'm gonna change that language a bit depending on who I'm talking to. Hopefully, no better than to tell a neurosurgeon they need to order an MRI or something. They hopefully have that covered. But I hope that answers the question. I know some folks are able to order the imaging directly. I think the Miami VA, I have a colleague who worked there and said they could order MRIs directly. But I haven't ever run into any problems of them pushing back. Most of the time they're thankful or will tell me, why didn't you tell us to order this later? So maybe that's just the hospital culture a bit. Um, but yeah, and there was a great set of papers out a couple years ago. I think Karen McCoy was on one about what physicians' views are of our neuropsych recommendations, and that was one thing they discussed. There was another paper too. I apologize, I forget the authors, but uh, that is one recommendation that is sometimes appreciated and sometimes not. So again, trying to kind of know the culture of your hospital, who your referring provider is, and knowing the audience of how you're going to approach that if you think something needs to be ordered, would be my recommendation. And that may mean back channeling them and asking for something. I've done that with a couple of patients who may have had NPH that they were difficult and neurology didn't want to work with them. So we, back channeled and said, hey, look, you did this MRI, ventricles look big. Can you please? And that was received a bit better. So medical necessity, absolutely, yeah. Okay. Were there any other questions? Otherwise, I know I've kept everyone here a little bit long, so I apologize for that.
There are lots and lots of thank yous in the chat. So we are so appreciative that you donated your time and knowledge. Thank you so much.
Absolutely. I appreciate that you think it's worth it for the cat jokes. Thank you. I'm going to put there was a question for my email. I will put it here in the chat. There I am. Okay. So thank you again. If anyone does have any other questions that come up, feel free to shoot me a line. But appreciate you all and appreciate Absent for hosting this. Hope everyone has a great rest of your Friday.
Thanks. Bye-bye.
Thanks.